Welcome to Mastering and Guideline in Ultrasound and Echo. Hi everyone. In this presentation, I am going to talk about differentiation of the constrictive pericarditis and restrictive cardiomyopathy. Before you go there, I strongly recommend go review very fast. They are short clips. Check all of them and then come review this one. It will help you a lot. And at the end of this presentation, I'm going shortly mention about cardiac tamponade and differentiate it between all those three from each other too. So let's do it. As we know, about half of the cases of heart failure go to the category of heart failure with preserved ejection fraction. In another word, 50% of cases of heart failure are the type of the diastolic dysfunction heart failure. Means the EF is almost normal, equal or more than 50%, but we have heart failure due to diastolic dysfunction. Among those diastolic dysfunction heart failure, about 10 to 15, sometimes 20 in some literature, 20% of the cases are due to these two conditions, constrictive pericarditis or restrictive cardiomyopathy. Before I go ahead, I have to mention that if you go read the old literature, sometimes they called it constrictive pericarditis, cardiomyopathy, and constrictive pericarditis, they called it restrictive pericarditis. But nowadays, the common name for this situation is this one, restrictive cardiomyopathy and constrictive pericarditis. The common feature among these two condition and entity is one thing. Both of them, they have diastolic dysfunction, but the pathophysiology of the diastolic dysfunction among those two are different. In restrictive cardiomyopathy, due to disorder, functional or structure, intracellular or intercellular matrix of the myocardium, the myocardium doesn't expand and stretch correctly and easily. So myocardium has some kind of the stiffness. But in the constrictive pericarditis, myocardium usually is a normal structure and function, but it can be abnormal, but it doesn't go to the category of the cardiomyopathy. The most important feature of the constrictive pericarditis is that the pericardium, instead of the being thin and high compliance, in the constrictive pericarditis usually become thick and stiff, and so the compliance of the pericardium decrease, and it doesn't let the ventricles and atrium too expand easily and normally. So we have diastolic dysfunction in this situation too. Sorry. The cause of the restrictive cardiomyopathy can be divided in three categories: idiopathic, familial, that is genetic, and secondary. Most of the cases are secondary, that can be divided in three categories itself: infiltrative, non-infiltrative, and storage. At top of them, endomyocardial fibrosis, hypereosinophilic syndrome, and amyloidosis are the most common cause of the secondary restrictive cardiomyopathy. We have to remember that infiltrative and storage disorder in the cardiomyopathy can represent itself in different way. As you know, for example, sarcoidosis and hemochromatosis, usually they represent as the type of the dilated cardiomyopathy, or so on. So remember, depending of the situation and mechanism and process of the disease, those secondary can represent a different way. restrictive, dilated, or hypertrophic cardiomyopathy. Among the causes of the constrictive pericarditis, infections are at the top, and at the top of them, tuberculosis in the undeveloped country and viral in developed country are the most common cause of the constrictive pericarditis, but it can be due to the trauma, inflammatory, especially rheumatoid arthritis and lupus, radiation, idiopathic neoplasia, especially metastatic, and end stage of the renal disease. As here you can see, radiation can cause both situations. In both situations, usually fibrosis is the mechanism. Depending on which part of the heart involved in radiation, it can create restrictive cardiomyopathy or constrictive pericarditis, or the combination of both. In the cardiomyopathy caused due to the myocardial fibrosis, and in the constrictive pericarditis it causes sclerosing of the pericardium. Here I have to mention that constrictive pericarditis has different variants, that they have a little different clinical and laboratory or imaging finding a little different. I'm not going to talk about those variants in this lecture. In another complete lecture that I allocated to the constrictive pericarditis, I'm going to talk in detail. Cardinal manifestation of both conditions almost are similar and represent as a heart failure, like shortness of breath, lack of energy, fatigue, limited of the exertion and energy, and at the advanced stage, the sign and symptom of the high central venous pressure, like peripheral edema, congestive pulmonary congestion, ascites, hepatic congestion, portal hypertension, pleural effusion, and so on. So both of them can be very similar to each other, and there is not any sign or symptom that differentiated those two from each other, except maybe we can see those clinical finding of the etiology of the disease, like that. For example, for tuberculosis, we have some finding for tuberculosis, or for amyloidosis, maybe especially in systemic, we will see some pulmonary or dermatology finding. Otherwise, there are not any specific sign and symptom. The gold standard for diagnosis of these two situations and differentiation of each other is echo and CMR. Echo is the first step we evaluate, and most of the time is enough for diagnosis of each of those situations and differentiation of them. Let's go one by one, because there are a lot of things we have to talk about that. First, echo 2D finding. In constrictive pericarditis, pericardial usually is thick. That is, I talk in another lecture how we measure it and how we diagnose this. It should be, if over 2 millimeter thickness is, we call it pericardial thickness, and it's in 80% of the cases of constrictive pericarditis we can see this thickness. So 20% they don't have thickness of the pericardium. In restrictive cardiomyopathy, usually is normal. Pericardial calcification, especially in those related to bacterial, in the constrictive pericarditis, at top of them tuberculosis. In 20 to 30% of cases we can expect to see calcification. If calcification is enough thick, enough at least 2 millimeter, we can see some, beside of the hyper echo pericardium, those spots that has enough calcification, we can see posterior shadow from those spots. but the diagnosis of pericardial calcification usually is done by chest X-ray or CT scan. In the restrictive cardiomyopathy, usually we don't have calcification. Pericardial effusion, usually we can see some degree of the pericardial effusion, but in restrictive we don't have usually. Ventricular size in the constrictive pericarditis usually normal, but in the restrictive, in both situation, in condition, both ventricular size usually are normal, but is usually many times no. Atria in the constrictive pericarditis usually is normal or mild enlargement in most cases. Sometimes a little up to moderate you can expect to see. But in the restrictive cardiomyopathy, almost always bilateral enlargement that is moderate to severe we can see and expect to see. And because of that, in MR and TR is very common in the restrictive cardiomyopathy, but in the constrictive pericarditis, there is not related to that condition cause MR or TR, mitral regurgitation or tricuspid regurgitation. Maybe if there is another primary or secondary problem from for the both the valve, we can expect to see some degree of the regurgitation. Septal motion abnormality in most cases of constrictive pericarditis we can see, but in restrictive cardiomyopathy is very uncommon. Maybe sometime we can see that. Shortly I am going to talk about those septal motion abnormality, what those are. And another 2D finding we can see is IVC, the size and collapsibility of the IVC. In constrictive pericarditis, over 90% we have a plethora IVC, means dilated and non-collapsible, or at least less than 50% collapse. In the restrictive cardiomyopathy, usually we can see that one too. As a general, because this is very important, a general rule, whenever we see IVC plethora and a septal motion abnormality, the septum has bouncing or shudder or those other stuff that I'm going to talk about that. Whenever you see in any patient that you are scanning, you see IVC plethora and with a septal motion abnormality, always you have to think about these two and rule out those two conditions. Now let's go see what those septal motion abnormality we can expect to see. At the most important on top of the septal motion abnormality in the constrictive pericarditis is a septal bounce or bouncing of the septum. In this situation, the septum during diastole is shaking. During diastole is shaking, as you can see. We call bouncing, or is exactly you can see shaking. The reason for shaking is that the feeling of the rapid feeling in the constrictive pericarditis is very fast. Most of the feeling happen at early diastole and correspond to the E wave on the mitral valve inflow or even M mode. So at that moment, when right after early diastole rapid feeling, suddenly the feeling finished and stopped. This stopping suddenly feeling cause shaking septum during mid early diastole or mid diastole, and we can see very easy on the 2D, especially on the apical forechamber. I have to mention that septal bounce is not specific for the constrictive pericarditis, and we can see in the after open heart surgery, mitral stenosis, pulmonary hypertension, left bundle branch block, and left or right ventricular volume overload, and so on. So even though the pattern of septal motion abnormality is a little different, but this one is not specific. But if this sign is come with the IVC plethora, that it gives a strong indication that most probably patient have constrictive pericarditis, and with other finding we have to rule out that situation. In M mode, when we do M mode on the when the patient has bounce symptom, bouncing, we can detect it on M mode, as we can see as a notch at early diastole of the septum on the M mode. That in this situation we called it shudder sign. Here bouncing, there we called it shudder sign, and is the same as the septal bounce on 2D. Another finding on 2D is respiratory variation of the septum movement and diameter of the RV and LV. As you know, we have usually the normal situation during inspiration and expiration. The volume input to the RV and LV are different. In the constrictive pericarditis or cardiac tamponade, during inspiration, the blood flow in the right side increased, and so when inspiration here, the right ventricular diameter increased and showed the septum moved toward the left ventricle. As you can see, diameter increased. In exhale or expiration, left ventricle flow increased, so the septum moved toward the right ventricle. To this movement we call ventricular interdependence and respiratory variance of the septum, that we can detect it on the M mode, 2D, CT, MR, and all of them. Another finding in the constrictive pericarditis, maybe we can see, is posterior wall flattening. As you know, during diastole, all the left ventricle expand, and so when we do M mode, the posterior wall, whatever it is, posterior wall should be little by little expand and go out. As you can see, oblique goes, it means that expanding of the posterior wall go out, and here on the image M mode you can see it goes down, oblique movement. But in the constrictive pericarditis, because of restriction of the movement of posterior wall due to stiff pericardium, this expansion doesn't happen, and the posterior wall looks like horizontal, especially on the mid to the late diastole. At this level it looks like flat. If we have increased sweeping speed, we can see much better. Again, this one is not specific for the constrictive pericarditis. I forgot to mention that those abnormal septal movement and respiratory variation only seen on the constrictive pericarditis. We don't see on restrictive cardiomyopathy. The most important and specific and diagnostic finding for constrictive pericarditis and differentiated from the restrictive cardiomyopathy is Doppler finding that include pulse wave Doppler and tissue Doppler. Now let's go see in detail what's happened. As we know, the hallmark of the constrictive pericarditis is equalization of the diastolic pressure in all four chambers. The pericardium, stiff pericardium, act as a metal balloon that hold the heart. So diastolic pressure in all four chambers almost equal. That is the hallmark of the constrictive pericarditis. And in cardiac catheterization, we can detect it, the pressure inside of the all four as a deep plateau or root square sign on the intracardiac ventricular pressure, as you can see here. Anyway, let's see what happened during inspiration and respiration in constrictive pericarditis. As I mentioned, the stiff pericardium doesn't let the changes of the pressure inside of the thorax or chest apply to the inside of the heart. In other words, when pressure inside of the chest, intrathoracic, become negative, that it happened during inhale, those negative pressure doesn't apply to the intraventricular left and right and atrium, both atria. But this negative pressure increased the inflow inside of the right ventricle. So in that situation, we will have very tall S and D, significant S and D, and increasing tricuspid valve inflow, that this one cause combined to the decreasing inflow to the left ventricle, bulging or bouncing or tilting to the septum to the left ventricle. And we can see S and D little decrease, and E and A decrease too. Let's see what happened during exhale. With exhale, the inflow to the left ventricular increased and to the right ventricle decreased. And we can see those pattern reverse. So S and D decrease, especially D more, and even A and C that I explained in the middle hepatic Doppler become more prominent and create diastolic reverse flow, as you can see here. Usually some expert or literature annotated as a DR, diastolic reverse. And E and A on the tricuspid drop, but opposite from right side increased. S and D, especially D, increased more, and E and A increased during exhale. And that is the specific pattern and characteristic pattern of constrictive pericarditis. That is, we can see these changes in the cardiac tamponade too. But in the restrictive cardiomyopathy, we will not see those changes. Here we have hepatic vein, middle hepatic vein during exhale. As you can see, a reverse flow at the first pulse of the post expiration or exhale. We have negative or reverse, not negative, reverse flow. Here is positive. Now see, go more accurate and talk about those findings. First of all, in 80% of the patient with constrictive pericarditis, this respiratory variation is positive, mean more than 25% we will change in the E velocity during inhale and exhale. That I explained in another lecture how we do it technically. You can go check it out. But in the restrictive cardiomyopathy, we don't have respiratory variation positive. It's normal changes, less than 10%, or 5 to 10%. Another finding is in tissue Doppler of the mitral valve. In a mitral valve, E usually will be normal. E prime usually will be normal, equal or more than 8 centimeters per second. And the ratio of the E to A we will be equal or more than 1.5, and E to E prime is less than 50. The most important finding on the constrictive pericarditis that medial E prime is taller or higher than lateral E prime. As you know, in normal situation, the tissue Doppler of the E prime is that represent diastolic, early diastolic, is medial is less than lateral. Lateral is higher. But in the constrictive pericarditis, we have paradox this change. This amount of the E prime in medial become higher than lateral. How much percentage? Over 80% of the cases with constrictive pericarditis, they have this paradox E prime of the medial that become bigger than lateral E prime. Only 80% or 80 to 90%. The reason for that is that why lateral drop compared to the medial? Because in most cases, in lateral is confined with an adhesion with the stiff pericardium, as you can see here. And this one restrict relaxation of the lateral annulus of mitral valve. But the septum doesn't involve in this process, so that will be normal. And we know constrictive pericarditis has normal myocardial activity. So because of that process, medial go higher than lateral. In those cases that the lateral is not severely involved in the constrictive pericarditis, adhesion, fibrosis, all those that cause restriction of movement of the lateral annulus. In those cases that is not involved, still lateral will be higher than medial. So is about 10 to 20% of the cases we see such thing, such a pattern. So generally, whenever you see the medial E prime is higher than lateral E prime, always think about constrictive pericarditis. In the restrictive cardiomyopathy, this the relationship, the ratio between medial E prime and lateral E prime is the same as the normal people, that E prime medial is less than lateral E prime. Another finding that we talk about that is reverse hepatic vein Doppler. In the restrictive constrictive pericarditis, this reverse flow happen during expiration or exhale, but in the restrictive cardiomyopathy, it happened during inhale. So exhale in the constrictive pericarditis, we have reverse hepatic flow, and in restrictive cardiomyopathy, we have reverse flow in hepatic vein in inhale. Whenever we have this 3 parameter in any patient with the septal bouncing, the specificity and sensitivity of diagnosis of constrictive pericarditis will be over 90%. Here is just a schematic of the differences between those 3 situations that can should be differentiated from each other: constrictive pericarditis, pure constrictive pericarditis, effusive constrictive pericarditis, and cardiac tamponade. That I am going to talk in detail in another lecture under the name of the constrictive pericarditis. So we are done, and don't forget this is for public, so please, if you like it and you thought it was useful, share it. Up to the next time, have a wonderful time.